Hello, good afternoon, good morning, good evening to all of you. Welcome to this Childhood Cancer Early Diagnosis and Appropriate Referral CEDAR webinar on Hodgkin lymphoma, organized by SIOP and IPA under the guidance of Dr. Sari Khan, who is also present here today. My name is Reineke Schoot and I'm a pediatric oncologist working at the Prinses Maxima Center for Pediatric Oncology in Utrecht, the Netherlands. And I'm a member of the SIOP Europe Education Committee and the SIOP International Education and Training Committee chaired, organizing the CEDAR webinars. I have two co-moderators with me today, Dr. Maya Prasad, Professor of Pediatric Oncology at Tata Memorial Centre, Mumbai in India. She has been serving as a co-chair of the SIOP Nutrition Network and is an active member of the SIOP Education and Training Committee. She has special interest in pediatric solid tumors, supportive care in pediatric oncology, and late effects in survivor of childhood cancer. And my second co-moderator today is Dr. Basim Al-Zubi, Senior Consultant Pediatric Endocrinologist at Prince Hamza Hospital Amman and Head of Pediatric Directorate at Ministry of Health. He's President of the Union of Arab Pediatric Societies and Jordan Pediatric Society and the co-president of Italian Arab Pediatric Society. He's also serving as a member of Executive Committee of the Union of Mediterranean and Middle East Pediatric Societies, and he's a former member of IPA's Standing Committee. As said, the CEDAR webinars are a collaboration between SIOP International and IPA and aims to improve the knowledge and understanding of general healthcare providers about the initial care of pediatric patients suspected of having cancer. Today, we hear practical advice from oncology experts from around the world on how to identify children with a suspicion of Hodgkin lymphoma at the earliest possible stage. There will be simultaneous Spanish translation. You can choose your language of preference, English or Spanish, after clicking the globe at the bottom right of your screen. We start today's webinar with three speakers. First, a case scenario presented by Dr. Ganda Ilmana from Indonesia, followed by a lecture on when to suspect Hodgkin lymphoma by Dr. Mauricio Castellanos from Guatemala, and then a lecture by Dr. Jennifer Geel from South Africa on the approach for diagnosis, initial management, and referral. After the lectures, there will be a panel discussion with three excellent panelists today, Dr. Ramandeep Arora from India, Dr. Francesco Ceppi from Switzerland, and Dr. Szymon Skoczen from Poland. There are some housekeeping rules. You can pose any question to the speakers or panelists at any time in the Q&A section. There is unfortunately no voice option for the audience, but the experts will reply to as many questions possible through the Q&A, either in writing or real life in the time after the panel discussion. All participants can receive CME accreditation through the SIOP office after having completed the evaluation. And I wish you a very interesting webinar, and I would like to start introducing our first speaker, Dr. Ganda Ilmana. She is a fellow pediatric hematology and oncology at Universitas Indonesia Cipto Mangunkusumo Hospital Jakarta in Indonesia. The floor is yours.
Hello everyone, thank you for the opportunity. My name is Ganda Ilmana. I am a fellow in Pediatric Hematology Oncology, Universitas Indonesia Cipto Mangunkusumo Hospital, Jakarta. Today I will present a case of Hodgkin lymphoma with delay in diagnosis and referral. Our patient is a 12-year-old female with symptoms of multiple lymph nodes enlargement in the right coli area, accompanied by night sweating, fever, and weight loss. Initially, she was diagnosed as tuberculosis infection and was treated, but there was no improvement. 3 months later, she was referred to Jakarta, where a biopsy was done, but there was loss to follow-up due to financial problems. This patient came from Timika, Papua, which is very far from Jakarta, with a distance of almost 4,000 kilometers with 6-hour flight, so it was very difficult. 6 months later, due to progressive swelling of the lymph nodes along with abdominal pain, she was referred again to Jakarta, but this time she received financial aid from a local foundation. There was no other medication or treatment history. The immunization was incomplete. no family member with malignancy. Both of her parents were low educated. On physical examination, she was moderately malnourished with no sign of respiratory distress. There were multiple lymph nodes in the right Geel area, which were firm, painless, with the biggest size of 7 centimeters, and also splenomegaly subnerve 4. On blood examination, we found microcytic hypochromic anemia with eosinophilia and markedly increase of ESR and LDH level. On the chest X-ray, there was mediastinal mass with shifting of the tracheal to the left side. The biopsy result was consistent with classical Hodgkin lymphoma, mixed cellularity type. The PET-CT scan revealed a multiple enlargement of hypermetabolic lymph nodes in the cervical, mediastinal, and abdominal area with splenic, sternum, and vertebra involvement. The bone marrow aspiration was positive. We diagnosed this patient as Hodgkin lymphoma stage 4. The treatment consists of chemotherapy and radiation therapy. We can see that the delay in diagnosis and referral can result in such advanced presentation of malignancy, and the support from the government or local foundation is very important, as this patient can finally receive standard treatment. And also we have to monitor for the treatment toxicity and of course the compliance, since the risk for treatment abandonment is very high in such cases. I think this is the end of my presentation. Thank you for your attention.
So thank you, Dr. Ganda, for your very concise presentation. And once again, we welcome all participants from all across the world who are presently attending this webinar. It is my pleasure to introduce Dr. Mauricio Castellanos, who is a pediatric hematologist oncologist from Guatemala and has been serving since 2002. He is also principal investigator of the AHOPCA Hodgkin lymphoma study since 2004 and is also the founder of CLAHOP, which is the Latin American Pediatric Hematology Oncology Consortium. Over to you, Dr. Castellanos.
Thank you. Okay, good morning. Thanks for the invitation. Today I'm going to speak about when to suspect a Hodgkin lymphoma in pediatric patients. I think this kind of project, they're really going to make a change. So thank you to SIOP and IIP for this opportunity. First, I would like to put you a little bit in context. And as you know, 180,000 patients we expect to see children with cancer. But it's interesting that 81% of these patients, they will be in low and middle income countries. Why I mentioned this? Because as you can see, in the different regions, we have a different survival. So I think with this kind of project, this has to change. And the way we think this could happen is working in a global way. I suggest you to read this article. This shows you how the things are working. But the most important thing is that we have to learn lessons from high-income countries and low-income countries. I think everybody can learn from everybody. So this is very important to change the opportunity to cure our children with cancer. It's very important to refer the patient. Talking about Hodgkin. Well, as you know, children and adolescents with Hodgkin lymphoma have excellent outcomes in high-income countries. But it's not always the case in the low-middle income countries. Why? Because we have long history of symptoms and poor general condition. The malnourished. In my country, 50% of our patients are malnourished, and 30% of them arrive late to the hospital. And this really makes it difficult to cure them. But that's why this kind of talks can help, because the early referral is very important when you suspect your patient can have Hodgkin lymphoma. It's incredible. We're in 2023, and a lot of health people who works in our region in Central America still believe that patients with cancer can't cure. So since 1998, we start to work together as a region in Central America. And right now we are 8 countries working together, sharing some protocols. And why I mention you this? Because the only way to change the mentality of the people who thinks that the cancer, children cancer can cure is with results. As you can see in Central America, 87% of our patients survive to Hodgkin lymphoma. So it doesn't matter the resources. It's very important to give a chance our child to look for the treatment. So it's very important to suspect and refer the patient. When to suspect? I'm going to try to give a little tools for you just to suspect when a patient can have a Hodgkin lymphoma. First, are more males than females. The age is very interesting because in developing countries, childhood cases are associated with primary ABV infection. That's why we have an early peak, less than 10 years old. And we have another peak, 15 to 34 years, when they have associated with delayed primary IBV infection. The older group, the peak is 55, and in developed countries, the peak are 30 years, and they are not associated to Epstein-Barr virus. We made a study in our country, and we find 90% of the tumor cells positive to Epstein-Barr virus. And 60% of our patients are less than 10 years old, and 22% of patients are less than 5 years old. So the age depends of where the patient is. So this is very important to have in mind. This slide is only to show you the red stem cell. I don't know if you can see the arrow, but this is very hard to make the diagnosis of Hodgkin lymphoma. It's not easy. As you can see, there are a lot of cells around the red stem cell. So I show you this because sometimes you try to do the biopsy in your center, and this can delay the referral. It's better if you have the suspect of Hodgkin lymphoma, send the patient to another hospital who has the experience to make the diagnosis to avoid the delay in the diagnosis. I think this is the slide that can show you, that I can show you, that can help you to suspect the Hodgkin. But as you know, Hodgkin lymphoma is a slow grower lymphadenopathy. It's a painless, this is very important, persistent painless lymphadenopathy. And this associated with constitutional symptoms, 33% of the patients of Hodgkin lymphoma can have B symptoms. What are these symptoms? Unexplained fever, drenching night sweats. This is very important. It has to be drenching, and weight loss of 10% in 6 months. So if you suspect or the patient can have these symptoms, it's better to refer the patient. Sometimes you can give antibiotics, and usually they don't get better. So persist the painless lymphadenopathy. So if you have the doubt or you suspect Hodgkin lymphoma, refer the patient. It's better to refer the patient, and it's no cancer, it's okay. But if they have a lymphoma, it's better to send them early. Lymphadenopathy usually the most of the time around the neck, but you have to make a very good physical exam because you can have lymphadenopathy in all these places, and you can find the best lymphadenopathy to take a biopsy. So when you make a physical exam, please make a hole trying to find where are the lymphadenopathy. I also suggest to you to read this article who can show you the results not only of high-income countries, but only low and middle-income countries, the results, the therapies. So why I'm showing you this? Because yes, the children with cancer can be cured. Doesn't matter the level of resources that you have. You only have to choose the right way to refer the patient on time and try to find the best treatment with the resources that you have. This slide, I just want to show you because the mediastinal masses are differential diagnosis of Hodgkin lymphoma. And as you can see, depends on the level of resources, 0 to 3, for example. Doesn't matter the level of resources, but you can do the best what you have. If you have a PET-CT, very good. But if you only have a chest X-ray and abdominal USG, you can use it too. Why I'm showing you this? because the mediastinal mass, that in the next talk, they're going to talk a little bit more about this. I'm showing you this because as you can see here, the trachea is very narrow. So sometimes in the hospital that you are working, they can do the biopsy, but you always have to make sure that the airway are clear because you can have problems. So it's better to refer the patient. Doesn't matter, you have the possibilities to do the biopsy. Sometimes doesn't have the experience, so this can have a problem, and you can have an obstruction or a compression syndrome due to the mediastinal mass, and this can be a very big problem for the anesthesiologist. So I try to repeat this. If you suspect, refer the patient. This is very, very important. The USG, well, they can help us to see the lymphadenopathy. They can help us to see the hypodensities in the spleen and liver. And that can give you another tool to suspect that the patient has Hodgkin lymphoma. So with the chest X-ray and the USG, you can have an idea what to do. Like I said before, if you have CT scan, or if you have MRI or PET-CT, okay, use it. But it's very important to understand that we have different resources. So we need to know what to do with the resources that we have. So that's why I'm showing you this. So to finish, I would like to give you this to you. Pediatric Hodgkin lymphoma has a very good prognosis, even in low and middle income countries. So you are very important. If you suspect and if you refer early the patient has the possibility to be cured. Doesn't matter the level of resources that you have. You can give the best that you can have, and these patients can be cured. And I think this kind of projects, this kind of harmonization, international harmonization, this really help, because we can learn from the high-income countries, of course, and we learn a lot. But our experience in low and middle-income countries can help to another low, middle-income countries to don't make the same mistake that, for example, we made before. So we can share that, and we can change the possibility of cure of our patients. I always put this slide, work together, and you will get better results. Doesn't matter who in the top, doesn't matter who is in the bottom. The important thing is to cure our patient. And as here said, no child should die of cancer. Cure for more, care for all, that is really important. We can do the difference. So thank you for the opportunity to share with you this. I hope this can help. And don't forget, doesn't matter the resource, you can do a lot for your patient. Thank you.
Okay, thank you, Professor Mauricio, for this excellent presentation. And first, I want to thank the Society of Pediatric Oncology, the International Society, for this great webinar and this series of webinars, and to thank them for the collaboration with the International Pediatric Association. I want to remind the attendees, if they have any question, to write that in the box of a question and answer, please. And it's my pleasure now to introduce our next speaker, Professor Jennifer Geel. Professor Jennifer is a pediatric oncologist and adjunct professor pediatric hematology and oncology department at University of Witwatersrand, Charlotte, Mexico, Johannesburg Academic Hospital. She is an active member of SIOP Africa and former co-chair of SIOP Global Health Education and Training Working Group. Professor Jennifer will talk to us about the approach for diagnosis, initial management, and referral of the cases of Hodgkin lymphoma. Please, Dr. Jennifer.
Thank you very much. Hi, everyone. I'm delighted to have this opportunity to talk to so many of you about the diagnosis, initial management, and referral of patients with Hodgkin lymphoma. And it's lovely to see so many familiar faces in the audience. Let's explore the issues around the diagnosis of Hodgkin lymphoma. It depends very much on where you are and the capabilities of your unit and the specialists around you. The options are fine needle aspiration, which has been phased out in most high-income countries, incisional biopsy, excisional biopsy, and bone marrow. This is a slide from a fine needle aspiration biopsy taken from a patient with Hodgkin lymphoma. As you can see, there are lots and lots of inflammatory cells. Top right, you can see a plasma cell. There's a lovely little eosinophil and a histiocyte. Bottom right, we finally see the Reed-Sternberg cells, and you can see they're not the majority here. And on the left, there are two other completely different looking Reed-Sternberg cells. And just above that is a neutrophil. And that's one of many neutrophils. And the issue with this is that there are so many inflammatory cells, and it depends very much on whether you get a representative sample from your small needle and whether the pathologist looking at the slide can pick up these Reed-Sternberg cells, which are in the minority, and they're surrounded by so many inflammatory cells. But some places do have this capacity, and their pathologists can make a very accurate diagnosis. However, it's not enough to make a histological subtyping diagnosis. So what's really gold standard is a biopsy, preferably an excision biopsy. Some people do perform an incisional biopsy if the availability of surgeons is limited, or if there are problems with anesthesia, or if they don't have access to a pediatric surgeon. But to really make the diagnosis, the histological subtype and diagnosis of Hodgkin lymphoma accurately, you need to take the whole lymph node out. The best thing is to take one that is relatively large and accessible, and one that you consider to be representative. So you ask the surgeon to take out a large whole lymph node, and they send it off to a good laboratory. So on the top left, you can see nodular sclerosis. You can see those clear streaks of fibrous bands surrounding many, many inflammatory cells. And when you look at higher magnification, you'll eventually be able to pick out the minority of Reed-Sternberg cells. But they can represent less than 1% of the nodal mass. On the top right is mixed cellularity, which is more common in industrialized settings. Bottom left, on a lower magnification, is lymphocyte depleted, which is quite rare in children and adolescents. And bottom right is lymphocyte rich. Now, lymphocyte rich Hodgkin lymphoma must not be confused with nodular lymphocyte predominant Hodgkin lymphoma, which is not considered part of classical Hodgkin lymphoma. It's important to note that Hodgkin lymphoma cannot be diagnosed radiologically, so you do need to do a biopsy. If you do an incisional biopsy, you may be able to make the diagnosis, but you can't, you can hardly ever diagnose the histological subtype. And the treatment of classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma is quite different. So it's important that you do a proper excisional biopsy if at all possible. And just to note, on bone marrow trephine biopsies, many people seem to think that you can diagnose all sorts of malignancies on a bone marrow biopsy. But you can only diagnose it if it comes from the bone marrow, like in a leukemia, or if it is spread to the bone marrow. For example, a Hodgkin lymphoma can do that. But you certainly can't figure out the histological subtype. So it's really not the preferred modality of choice. It's important to document the B symptoms. There are really only 3 kinds of B symptoms. So there's fever, there's night sweats, and there's significant loss of weight. It's very important to document the size of the lymph nodes or the lymph nodal masses, because this does have prognostic significance. And before you refer a patient, it would be appropriate to do a full blood count with a differential, because this can help you, this can help direct you to whether the patient has bone marrow involvement, and also certain cytopenias can be prognostic. Very basic non-specific tumor markers that you can do are an erythrocyte sedimentation rate, ferritin, and lactate dehydrogenase, as all of these also have prognostic significance. We consider it in our setting in Africa to be vital to perform an HIV ELISA test, because people with HIV do have an increased incidence of Hodgkin lymphoma, It's not an AIDS-defining malignancy, but it's certainly associated with having had HIV for a period of time. And you need to diagnose it because you need to treat these patients slightly differently. They're more prone to infections and other complications. The next simple imaging you could do is the chest X-ray, which is very important for two reasons. One is the mediastinal mass that Dr. Castellanos spoke about, and one is because many of these patients may also present with tuberculosis. And it's extremely important to look hard for TB because it's known to present with Hodgkin lymphoma, especially in areas that are endemic. And it does affect the reading of many of these non-specific tumor markers. And of course, you have to treat it in parallel with treating Hodgkin lymphoma. And the worst thing, which does happen, is to diagnose a patient with HIV, Hodgkin lymphoma, and TB all at the same time. So you have to be on your toes to do that. The current standard of care for assessing a mediastinal mass is a chest X-ray, not a CT or a PET CT. And here are some pictures of chest X-rays from patients of ours on our National Hodgkin Lymphoma study. The first thing to note is that when you do a chest X-ray, it must be erect. If you look at the top left, there's a beautiful, pristine, nice, clear X-ray. It's been performed erect, it's got good penetration. You can see there's no mediastinal mass and no pleural effusion. But on the bottom left, unfortunately, this patient had their chest X-ray done when they were lying supine. And you can see the angle of the X-ray beams is different. And you might overread this patient as having a mediastinal mass. The way to determine if a mediastinal mass is significant or not is that it must be 1/3 of the cardiothoracic diameter. So what you do is you measure across the widest part of the mass, and then you measure across the widest part of the intrathoracic diameter, and then you divide it. And if it's more than 33%, then the patient is considered to have a mediastinal mass, which confers a worse prognosis. In the middle, we have a patient with a quite obvious mediastinal mass, as well as a pleural effusion. And surprisingly, pleural effusions are not really shown to be prognostic. And then on the right, we have a very strange looking X-ray with multiple discrete nodal masses. But again, if you draw the line across the widest part and across the intrathoracic diameter, you'll see that it's 1/3, which makes it significant. The staging is obviously very important. There are three parts to staging. There's clinical, anatomical, and functional. And the clinical part is where primary healthcare providers come in. So it's very important to look at the size of the lymph nodes. Nodal masses that are more than 6 centimeters in any axis are of a poorer prognosis. So this is most correctly measured on a scan, but you can get a very good idea clinically. And then the B symptoms, which we've discussed. So there are other symptoms which are associated with Hodgkin lymphoma, such as pruritus. And then there are constitutional symptoms such as fatigue. Some of the patients may be pale, but those are not the B symptoms that are associated with classical Hodgkin lymphoma, and they do not have prognostic significance. So the diagram on the left is just a schematic diagram of multiple lymph nodes, just to remind ourselves that there's a beautiful connected network all over the body. And we must remember that the spleen and the thymus are part of the hematolymphoid system. And on the right is the naming convention assigned to all these lymph node regions. And then we've got the Ann Arbor staging system, which is what we still use. If you have one nodal mass, either above or below the diaphragm, it's a stage 1. If there are 2 or more masses still either above or below the diaphragm, it's a stage 2. If there are nodal masses both above and below the diaphragm, that makes it a stage 3. And then a stage 4 involves extra lymphatic organs or tissues, so bone or bone marrow or liver. And this is a picture of 4 different patients who've had PET scans to stage their Hodgkin lymphoma. And you can see, so this is the functional staging. So what happens is we give a radio-labeled tracer attached to glucose, which is taken up by highly metabolic tissues. And then it goes and localizes where the active Hodgkin lymphoma is. So in stage 1, you can see there's there's a little arrow which shows one nodal mass with increased uptake. In stage 2, now you see suddenly a whole lot of them, but they're still all above the diaphragm. In stage 3, you've got cervical adenopathy, as well as this inguinal lymph node. So that's obviously a stage 4. And the stage 5 picture, the most striking difference is that the liver is much, much darker than the livers of the other patients. So that means that this patient has got hepatic involvement, making them a stage 4. And you can also see that the spleen is involved. So before you send the patient off to the relevant specialist or subspecialist, please do everyone a favor and don't give steroids, because the steroids partially treat the lymphoma, and that may give the patient the impression that everything is okay and that they don't need to present themselves to the pediatric oncology unit. Steroid administration can also cause diagnostic uncertainty, and if given before the biopsy, it can delay the diagnosis, which obviously has implications for receiving the correct treatment and for the overall outcome. It's very important to counsel the patient and the caregivers of the possible diagnosis, because it's really traumatic for the patients and the receiving staff when a patient turns up in a cancer unit without being told that they might have cancer. And if you do have the diagnosis, if you're sure that it's Hodgkin lymphoma, if you've got a biopsy result, you can reassure the patient and the family that the prognosis is good, even in the low and middle income country setting. So the referral procedures depend very much on where you are. In some places, you can pick up the phone and directly phone the pediatric oncologist and ask them to accept the patient straight away, and they'll take over from there. In other places, you have to have a diagnosis first. In that case, you need to speak to the pediatric surgeon, or if you don't have access to a ped surgeon, you can speak to a general surgeon and ask them to excise the lymph node. And I did say that you've got time with Hodgkin lymphoma, but you don't have infinite amounts of time. So it's best to get this done as quickly as possible, and then get that lymph node sent to a pathology laboratory that's got experience looking at childhood malignancies. Once you have your diagnosis, you refer to the pediatric oncology unit and you follow up to make sure that the patient is seen fairly quickly. The patient will also require referral to a cardiologist for a baseline echocardiogram, because some of the chemotherapy we give is cardiotoxic. And then we'll take over, and hopefully we'll get back to you in a few weeks to let you know that the patient is doing fine, and thank you very much for the referral. So just to reiterate, the prognosis is excellent. So please refer every patient that you see. Thank you very much.
Thanks, Dr. Geel, for this really very excellent presentation. And I think we'll go on to the panelists now. Next up, I'd like to welcome my good friend and colleague, Dr. Ramandeep Arora. Dr. Arora is a senior consultant pediatric oncology at the Max Super Specialty Hospital, New Delhi. He is also honorary head of quality care, research and impact analysis, CanKids India, New Delhi. He also serves as the secretary of the Indian Pediatric Hematology and Oncology Group, and has played a vital role in pediatric oncology clinical trials in India. And many of you may know him as the former co-chair of the SIOP Global Health Network. Please go ahead, Dr. Ramandeep.
Thank you, Maya. Thank you and good evening to everyone. It is wonderful to see 380 participants. That is such a great joy. Thank you to the previous three speakers. I think they very clearly illustrated the challenges of diagnosis, the good prognosis which the disease carries, the need for complete treatment, as Dr. Ganda very nicely showed in her case. From my perspective, and I just wanted to pick on one point which was mentioned by the speakers, and that was our challenge with tuberculosis. We in our country, and I think that resonates across much of low-middle countries, find that many of our patients would have received anti-tuberculous therapy prior to coming to or prior to getting the diagnosis made. And I think we all as general pediatricians have had experience of diagnosing tuberculosis, as well as the challenges sometimes when it's not so clear. But what we have to remember is that in the absence of clear microbiological confirmation, by empirically giving somebody anti-tuberculous treatment and not necessarily investigating the lymph node with maybe a biopsy, preferably excisional biopsy, you have a high chance of missing a non-tuberculous illness. And so if an FNAC provides you evidence of mycobacterium, then I think that is sufficient. But when you are not having that evidence, you have to be really sure before labeling somebody tuberculosis, as few months down the line, the child may present to a different physician and get labeled with a different illness, one of which would be Hodgkin's lymphoma. Thank you.
Thank you, Dr. Arora, for sharing your expert opinion with us. Next, I'd like to invite Dr. Francesco Ceppi. He's a staff physician in pediatric hematology oncology and a referral physician for pediatric leukemia and lymphoma and immunotherapy at the University Hospital of Lausanne in Switzerland. He's a PI in several research projects on pediatric leukemia, lymphoma, and cellular therapy. And he's a national PI for the European Network of Pediatric Hodgkin Lymphoma, second international intergroup study for classical Hodgkin lymphoma in children and adolescents. The floor is yours, Dr. Ceppi.
Thanks, Reineke. Yes, hello everyone. I want also to emphasize maybe on the presentation of Hodgkin lymphoma, not on tuberculosis, because it was done already by my colleague, but I think you see a lot of patients with adenopathies. And as was written in one of the questions in the chat, most of the time you give antibiotics because you think it's probably a bacterial infection. So my advice will be that you cannot do a biopsy for everyone, of course. And my advice is always to do a follow-up visit if you can. You will never do a mistake, because Hodgkin lymphoma is not a very aggressive disease. If you see the patient after 2, 3, or maybe also 4 weeks, it's never a mistake. And then if there is a persistence of adenopathy, you can do really an excision biopsy, that it's really recommended. And I think will be really important to do the biopsy in a hospital which has a pathology service that can give you also the answer to the biopsy. So please do follow-up visit. I don't think it's expensive, and you can really have a clinical follow-up of patients with adenopathies.
Thank you, Dr. Ceppi. And now I am pleased to introduce Dr. Szymon Skoczen from Poland. Dr. Szymon is a pediatric oncology and hematology with expertise in clinical transplantation. He is serving as professor at Jagiellonian University, Professor Krakow, Poland. Any comment, please, Dr.
Hello, it's pleasure.
Szymon.
Pleasure to meet you. Very good session, very good presentations. Some comments. As you probably know, we are classified as probably middle income country, and the longest time between the diagnosis and starting of treatment in our country, we collect data since 1971. And the longer time was between 1 and 2 years. So even in our country, we had such long periods to diagnose the Hodgkin lymphoma. The second, the picture of the disease changed. Since 1971 till now, in the beginning, we had four stages of Hodgkin lymphoma. In the beginning, in about 8% of patients. Nowadays, the fourth stage is about 25% of patients, and what is quite interesting, we have more localizations in bone marrow and more localizations in lungs. Probably the same is in the other European countries. I always ask the students what to do, because such patients are referred to our hospital typically on Friday, 2 p.m. And always is the question what to do in such situation when you have a child with enlarged lymph nodes in lower cervical region or supraclavicular, and can such child wait till Monday? Yeah. So of course, in all such situation, we should take very careful medical history, perform very careful physical examination, and perform X-ray to show if we have mediastinal mass or not. So I think this is the very common advice for everybody. Thank you very much.
Thank you very much, Dr. Skoczen, for your very valuable insights. I think we are now headed for the Q&A session. And thanks, there have been already several questions that have come into the Q&A box, and many of them have already been answered. But we'll start with some really important questions, I think, which need to be answered live and maybe elaborated as well. Let's start with Dr. Geel. Jennifer, if one question is, if there is a PET scan, do we need to do a bone marrow aspiration? And there's another related question, whether we should do a bone marrow aspiration or biopsy in all stages of Hodgkin lymphoma or only the advanced stages.
Okay, thank you. So if you're lucky enough to be in a place that can do a PET scan, then it's okay not to do a bone marrow. There have been various articles that have looked at whether not doing a bone marrow, or rather put it the other way, doing a PET scan, whether that upstages the patients. So they've shown that you're more likely to upstage the patient to a stage 4 with a PET scan. Doing an additional bone marrow doesn't give you additional information because it's obviously quite expensive, it's traumatic. But many places in low and middle income countries don't have access to a PET scan. So for example, in Africa, there are only 3 countries that can do that out of 54. So if you have a PET CT available, then do it. And you don't need to do the bone marrow if the bone marrow lights up on the PET scan. Sometimes there will be a false positive, but it's also not been shown to really affect the overall treatment, the staging and treatment of these patients. And then the other question was, should you do a bone marrow in early stages? Probably not. The yield is very, very low.
Thank you for answering this question, Dr. Geel. We have another question on urgent situations with mediastinal masses. Dr. Ceppi, could you repeat the question and answer it, please?
Yes, because it was mentioned in one of the presentation that you have not to give steroids before referring the patient, before doing the biopsy. And I think this question, it's very pertinent. And of course, when do you have an emergency situation with a mediastinal mass and a respiratory problem or vena cava superior problem, of course, in this situation, you have to save the patient, you have to give steroids and then put the patient in a safe clinical status and then refer to the patient. Don't worry, if a patient have a huge mediastinal mass, I think you will be always able to do a diagnosis afterwards. Of course, the patient that have huge mediastinal mass with respiratory or vena cava superior problem, most of the time have a lymphoblastic T-cell lymphoma that is a more aggressive disease, more frequent than in a Hodgkin situation. But if it's for a Hodgkin, of course, safety first.
Thanks, Dr. Francesco. I think we really have a very nice question from Dr. Michelle Farmer. What is the role of the general pediatrician to support the patient with Hodgkin lymphoma and to support the family? In your experience, are the general pediatricians informed about patient care and progress? Assuming the patient will recover, the patient will return to the care of a general pediatrician. And what do you suggest for low and middle income settings? Dr. Castellanos, would you like to answer this question, please?
Thank you, Dr. Armand. Could you please repeat the questions? I want to make sure to understand right.
Yes. It's a long question in several parts. So this, I think, is from looking at how exactly the pediatrician can look after a child with Hodgkin lymphoma across the spectrum of treatment. So firstly, what can the general pediatrician do to support the patient with Hodgkin lymphoma and to support the family, and what happens after the child completes treatment? So how can a pediatrician support a child who has been diagnosed with Hodgkin lymphoma firstly, and also after they complete their treatment and return to the community?
Thank you, Dr. Amaya. Of course, the pediatrician is very important because the first contact of the patient sometimes is with the pediatrician. So the important part is to suspect, and if you suspect, refer. Of course, if you can talk with the family, is very important. In low middle income countries, is sometimes the hospitals are very busy and they just refer the patient. But for me, going with the family, talk with the family and explain the things is very important, especially because you suspect it and you refer. And this is the most important thing, because we can treat patients if you don't refer or if you don't suspect. So after they finish the treatment, if the family have a pediatrician, of course, it's very important to give a follow-up together with the oncologist, so you can see the late effects together to take care of the life of this patient.
Thank you very much, Dr. Mauricio. I'm sorry, I'm just going through the questions. Actually, there are so many questions right now in the...
Maybe I will answer for one of
Yes, Dr. Szymon, could you please answer that question that we just...
There is a question for how long we can wait for a big cervical lymph nodes, more than 2 centimeters on both sides, if there is no other symptoms after receiving 2 weeks of antibiotics. Is the 2 months a good option, or earlier action should be done? So in our department, if there is no response after 2 weeks of antibiotic therapy, we usually take the lymph node for analysis. So we do not wait for 2 months just observing the lymph nodes, I think. Thank you.
Thank you very much, Dr. Szoczen. Reineke, would you like to put the next question, or
I wondered if Dr. Geel had another question that she would like to take, or that she's answering in the chat at this moment.
Yeah, I'm busy trying to get through as many questions as possible.
Please go ahead, Raman.
Yeah, I just noticed the last question, and I think this is an important question, which is about how do you deal with a mediastinal mass with which is compressing the superior vena cava, and you are not able to do a biopsy, right? Now, this is a situation which we encounter. In the context of Hodgkin's disease, in most situations, this would not be an issue because the disease grows slowly and you do not see the acute compression of the airways or the vessels, which I think this question is referring to. This is more commonly seen in non-Hodgkin's lymphoma or leukemia or certain other cancers. Having said that, once in a while we are faced with this situation, and you try and do as much as is possible without worsening the situation. And so you would try and get a diagnosis from an alternative source, for example, a bone marrow, if that is feasible. For example, a CBC film, if that's possible. If there is some pleural fluid and you can do a pleural tap, then that if possible. So you try these things. And if you can't do that, then when you are really pushed, you can empirically start some treatment. And then in most cases, you see a very rapid response. And then you have to be very vigilant. And whenever the window of opportunity comes, in say the next 24 hours or 48 hours, you go in and take a biopsy because the child has improved, and you would see that clinically. You would see the child improving clinically within 24 hours of, say, steroids. What treatment do you use? You could use simple steroids, you can use chemotherapy, you can use radiation therapy. In my experience, generally we start with steroids, and that does the trick. In rare situations, you may have to use other treatment modalities, but this is where you would want to work with the pediatric oncologist in case you're a general pediatrician. And if you're already a pediatric oncologist, then just keep fingers crossed, follow these principles. Thank you.
Dr. Geel, in the meantime, we selected another question. Could you repeat the question and answer it for us?
Okay, so the question was, occasionally we come across a patient with localized site, for example, cervical lymph nodes, and clinical basic assessment, which suggests stage 1 or 2, but the PET scan suggests bone marrow involvement. Is it a false positive of PET, or is it an uncommon presentation of Hodgkin? So in those cases, I would definitely suggest that you do a bone marrow biopsy. And the classical teaching is to do a bilateral trephine biopsy. So you don't really need the aspirate, you just need the trephine. And sometimes you'll find that there'll only be reactive changes in the bone marrow. Sometimes there may be something else like TB or some other kind of infection. And sometimes there actually is Hodgkin lymphoma involvement. So I've had a few patients like that where they've looked like a stage 2, but on bone marrow, they were a stage 4. So you have to take it case by case.
Thanks, Jennifer. Thanks a lot. I think I have a question for Dr. Szymon, and that's, it's a very important question, but also I think the answer could potentially be very long. What are the possible side effects of the treatment of Hodgkin lymphoma?
Yeah, I tried to answer such question. It was on the list.
Yes.
So, of course, we have acute complications and late complications. So acute complications during treatment are usually cytopenias, nausea, vomiting, and of course infections. And there are numerous late effects. And the most common are endocrinological problem. The other can be cardiological problem, especially if a mediastinal mass was irradiated. Then we can have problems with development when the treatment was involved at that time. And of course, what is quite important and can be life-threatening are late effects after the treatment, are second neoplasm after the treatment of Hodgkin disease. So in our department, and probably in many departments in Europe, we have a special program of follow-up of patient after the completing of treatment of Hodgkin disease, and we perform some tests, repeated tests, to be sure that we can recognize late complication on time. Thank you very much.
We have another interesting question. If there's any indication for the treatment of EBV infection associated with Hodgkin at diagnosis, and I'd like to invite one of the panelists to answer this question, maybe Dr. Ceppi. Or
if the question is if we can prevent Hodgkin in treating EBV?
Or of treating the infection when you have the Hodgkin. I think this is how I interpreted the question, but I don't know.
Okay. No, normally we don't treat the the B infection, but there are cases with mixed and EBV or when you have a predominant of lymphocyte that most of the time you treat with rituximab anti-CD20. So it's a sort also of treatment.
Thanks. Thank you so much, Dr. Francesco. We've had so many questions this time that we are barely able to, I think, keep up with those. But I think it's time for us to wrap up because it's nearly an hour since we started. I would request all the other participants who have not had their questions answered to please put their email address in the Q&A box, because we will get back to you with these answers if we are not able to actually type them in right now. So I would also like to acknowledge our IPA heads who have been so instrumental in getting these SIOP CEDAR webinar series going, Dr. Aman and Dr. Michelle Farmer. Thank you very much. They are co-chairs of the IPA SAG on non-communicable disease. And thank you so much for all the support and for making these webinars well attended and, you know, truly interactive kind of sessions. So before we wrap up, I'd like to really thank our speakers, our panelists, and all of you participants, as well as the admin team for this excellent and truly informative discussion. And thanks a lot. I would like to remind you that this webinar has one CME point. You will receive a survey link by email after this webinar, which you will need to fill in order to receive a certificate. I think we're also very happy to announce that the SIOP CEDAR webinars are recorded and available on the SIOP YouTube channel. We have our next webinar on the diagnosis and referral of Burkitt's lymphoma on the 3rd of February. That's pretty soon. It's just in 2 weeks' time. And we really look forward to having you all attend that as well. And Dr. Sagir has volunteered that he will be very happy to answer any further questions on his email address, which I think we'll just tap into the Q&A box as well. So I'll now hand over to Dr. Basim to wrap up the session.
Thank you, Dr. Maya. It was very interesting topic and excellent talks. I would like to thank all the speakers, the panelists, and all the people who are behind this event. I learned very much from this activity. I want to stress on for my pediatricians to take seriously any case of enlarging lymph node, especially if it is non-tender, non-painful, not painful, firm, rubbery, and on one side of the neck, because it is the most site of this Hodgkin lymphoma, site of lymphadenopathy and Hodgkin lymphoma. And also we have to consider very seriously the symptoms, the warning symptoms of Hodgkin lymphoma, like sweets, fever, and this and loss of weight. These are very important symptoms and should be taken considerably in serious manner in order not to miss any case. Essential investigation should be CBC, ESR, ferritin, LDH, chest X-ray, and if you want to do biopsy in your center, do excisional biopsy to diagnose Hodgkin lymphoma before referral. Thank you very much to all participants and to all faculty. And I also want to thank the Society of Pediatric, the International Pediatric Society for Pediatric Oncology, for this nice and excellent activity. Thank you all.